Good evening and welcome to an evening with strain brought to you by the American Society of Echocardiography. I'm Jim Thomas at Northwestern Memorial Hospital, and we are delighted to have you joining us. I think we have a registered audience of nearly 1,000 and plus a live audience here. So we're really looking forward to the next 2 hours to discuss the exciting new world of strain imaging. Let me just take a moment to introduce our panel to you. As you can see, we have the incomparable Roberto Lang from the University of Chicago, Nausheen Akhter, who's also from Northwestern, Maddie Jankowski, one of our ace sonographers, and then on the far end is Akil Narang, who will be serving as question wrangler tonight. So that any questions that you come in, he will sort through them and feed them to the audience. Speaking of questions, let me explain how this works. Since this is a live webinar, you do have the opportunity to have your questions answered by the panel of faculty. To ask a question, use the Questions tab on the left side of your screen. Feel free to ask a question at any point during the presentation. We will do our best to ensure that all questions are answered. However, this may not be possible depending on the number of questions answered. If possible, we'll try to answer them after the fact. I would also like to point out a feature for those who wish to take notes during the presentation. When you click on the Notes tab on the right-hand side of the screen, you will see a white text box where you can take notes during today's webinar. These notes will be emailed to you automatically at the end of the presentation. And finally, if you experience any technical problems during the course of the webinar, you can click on the Request Support button in the lower left-hand side of the player, and we'll have a technical expert there to help out with whatever problems you may have. Just to give you a little bit of a guide to what we're talking about tonight, I'll be talking about physics and instrumentation and something on intervendor agreement. Maddie will join us for tips and tricks for acquisition. Then we'll have a period of question and answer. Afterwards, Nausheen will come up and tell us how she uses strain in the world of cardio-oncology. Roberto will come up with a deep dive into applications in coronary artery disease and heart failure. We'll have another Q&A session, and then I will come back with some thoughts on valvular heart disease. Then Roberto for right ventricular issues and pulmonary hypertension. And then joining us from Denver is Bruce Landeck, the second, known to all who know him as Biff, and he will be discussing pediatrics and congenital heart disease. We had really intended to have Biff with us live on the panel, but you may have come to understand that a blizzard is moving into Denver tonight, and it was clear that even if he was able to get out today, he probably wouldn't get back to Denver before the spring thaw. So we thought better to have him join us by remote access there. So without further ado, I think I'll just launch right into our topic on the physics and instrumentation of this important new modality here. Now, we've known for a long time that there is a very complex combination of deformation that produces ejection. And deformation is just another word for strain. And you can see in these illustrations that my friend Peter Hunter from Auckland gave me that there's a combination of base to apex shortening, circumferential shortening, a twisting or shear motion to the heart or torsion, and this leads to wall thickening and ejection. And it's really a very combination of movements that are all tied into the very complex anatomy of the fiber architecture of the heart. Now, strain as a physical concept is actually fairly simple. It is a dimensionless index of a change of length. And so if you have a rubber band that's 10 centimeters long and you stretch it to 11, that's a 10% strain. If you let it shorten instead to 9, that's a minus 10% strain. And in many ways, it offers a relatively pure index of regional LV function, but until now has been difficult to measure. Now, strain, about 20 years ago, we were calculating strain using tissue Doppler, but this has largely gone out of favor because it detects only a single component of strain. It has a very limited scope of imaging. It's subject to noise, particularly strain rate, and it's very tedious to perform. Instead, we now derive strain directly from the B-mode image. And we use these little speckles that you can see in every ultrasound image here. These are not real structures there, but rather they are ultrasound interference patterns produced by very small structures in the myocardium. And the software is able to track the movement of those and look as they're moving closer together or farther apart and calculate the regional deformation in the heart. It's not really that new of an idea. The first time I heard about this was over 30 years ago at a computers in cardiology meeting, and they really had the same idea. It unfortunately, though, could not work on videotape at 30 frames per second. We needed digital images at much higher frame rates. So here we can see some examples. This is a normal ventricle here, 4-chamber view, and you can see the global strain for this view is minus 18.6, which is about average for ventricular function here. You can see the dilated cardiomyopathy over here, very low strain, and also a very low ejection fraction to go along with that. And I have put these in here on purpose to illustrate just how long we've been doing speckle tracking. These are from 2003 and are perhaps the first 2 examples I got when we started working with this 16 years ago. So it has been around a while, and there is a lot of evidence in favor of using it. Now you can take your 3 apical 4-chamber, apical 2-chamber, and long axis views and put them together into a single bullseye that in one flash demonstrates to you the overall motion of the heart as well as the global longitudinal strain, which is the most commonly reported strain parameter. It is a negative number, as you can see, but increase and decrease almost always refer to the distance from 0. Now, strain imaging is also becoming increasingly automated, and here we're very fortunate that the engineers keep getting better and better at this. This is a piece of software that all you have to do is clip a 4-chamber, 2-chamber, and long axis view and just present it to the software. It figures out which is which. It analyzes it automatically in about 5 seconds. You get your global longitudinal strain, which in this case is minus 16.8. Now, what constitutes normal? Well, there's a lot of normative data out here, but this was a fairly large study done when I was in Cleveland with Tom Marwick in Brisbane and researchers in Aachen, Germany. And for 242 patients, the average strain value was minus 18.6. These were all normal subjects with a standard deviation of about 1.5, and there was very little age variation in this group. Looking at strain rate, there was some reduction as people got older, but for strain itself, not much. So in general, what we say is that for global longitudinal strain below minus 16, that is closer to 0 than minus 16, that is abnormal in most circumstances. Between minus 16 and 17 is borderline. But remember, this is a continuum. So these cutoffs are really somewhat arbitrary here. Lower is bad, higher is good. Can we estimate ejection fraction from strain? Kind of, sort of, but really, why do we want to? There have been several papers that have tried to generate regression equations for ejection fraction from global longitudinal strain. But really, why not just measure the ejection fraction? We've made lots of progress making LV volumes more accurate and reproducible using things like 3D imaging and contrast. Global longitudinal strain is most interesting when it tells us something different from the ejection fraction. That is, it can predict future toxicity when GLS is low, but EF is preserved. And it may identify asymptomatic valve patients that are in need of intervention. Now, I just show one bit of data here that is really a fascinating study that I think illustrates the value of global longitudinal strain. This was from Korea, and they looked at over 4,000 consecutive patients admitted with acute decompensated heart failure. About half of them were HFrEF, a third were HFpEF, and then the remainder were kind of in the middle here. And it was a sick group. They had 40% mortality at 5 years. Now, just plotting a correlation plot, regression plot of LV ejection fraction versus global longitudinal strain shows definitely a strong correlation, but a lot of scatter in this. But more interestingly was when they plotted the probability of death against ejection fraction, and you can see across the entire range of ejection fraction, there was really no predictive accuracy from EF. In contrast, looking at strain, there was a very strong prediction. Low strain had very high mortality. Preserved strain had the best mortality here. So I think this in one slide shows you the prognostic value of strain. Now, I would be remiss if I didn't mention what some have called the Achilles heel of strain, which is inter-vendor reproducibility. And I go back about 7 years. This was a nice Japanese study that looked at GE, Philips, and Toshiba and a group of normal patients. And you can see that some of these look like a shotgun blast. And even the best of them had a lot of scatter and error between the various systems here. Now, that led Luigi Badano and me, when we were both presidents of our respective organizations, to form a task force bringing together technical experts, clinical experts, other societies, and industrial stakeholders from anyone with an interest in strain, hardware and software vendors, to come together to try to reach consensus on definitions and to reach consensus on a set of tools for quality assessment. So the first thing we had to do was really define how we were going to do strain, because it turned out a lot of the differences between the vendors was just they were measuring different things and calling it all strain. So I invite you to look at this paper from about 4 years ago, where we standardized the nomenclature, display, timing of end diastole, timing of end systole, the mathematical definition of strain, and how to define the regions of interest within the myocardium. Then Jan de Hoog developed these computer models of the myocardium and gave them to all of the vendors. And these all had set values of strain to them so they could tune their software to the point where it gave the right answer when they ran through their system. And then following that, Jens Uwe Voigt did a very nice study where over 1 week in April 2013, he had 63 patients come through, and they were scanned on 7 different machines, and 2 independent software measurements were made as well. And if we looked at the mean global longitudinal strain values for all of these patients, you can see that there was really a very close agreement. They were off by no more than 2% from each other. And if we look at the correlation plots, it was much, much better than that Japanese study that we had seen earlier. And interestingly, when we looked at the inter-observer variability between global longitudinal strain for all of these vendors versus the variability for ejection fraction for one of the vendors, Well, it turns out that the EF was actually worse than all of the other vendors. And furthermore, when we looked at the inter-vendor variability for GLS versus these time-honored parameters like E-wave and posterior wall thickness and interventricular septal thickness, global longitudinal strain was actually the one with the lowest inter-vendor variability there. So I think now, at least for global longitudinal strain, we can be very comfortable in using it from different platforms. Obviously, if you have the choice to use the same instrument, that takes 1 degree of variability out of it, but it's not necessary to do that. Now, one of the reasons why we're holding this webinar tonight is because there is a new CPT code that has just been announced by CMS, 93356, a new CPT code for strain. This has been a Category 3 or tracking code for several years. People have been billing it and showing CMS that this is an important part of the echocardiographic armamentarium, and now it has been announced as a Category 1 or reimbursable code as of January 1st, 2020. Now, we're not going to get rich off of this. The work RVU for myocardial strain imaging is 0.24, but that's actually a pretty good return compared to other things that have been added on to echoes previously, like spectral Doppler and color Doppler. This is in the hospital outpatient department. You don't get any increase in your practice expense, but if you were in a private office, you get a total of about 1.13 RVUs, which is really pretty good. And for the hospitals, if they track the billing for this, they should be able to get a higher overall payment for the hospital in the future. So it's important to keep billing for the practice expense aspect of this. So that's all I have to say by way of introduction. And now it's my delight to call up Maddie Jankowski, who followed me out here from Cleveland 5.5 years ago and has been doing just a great job in our echo lab here. And she's going to tell you some tips and tricks on how to do strain imaging in your laboratory. Maddie, take it away.
Thanks, Dr. Thomas. All right, and thank you everybody joining from offline and everywhere else. So I'd like to go through just a little bit of an introduction and background. Dr. Thomas covered a lot of this, but strain is used to improve our assessment of LV function. It's not to replace the EF, but it's just an addition. It measures the deformation of the ventricle, something that sometimes our eye can't pick up. And it can look at both regional and global function. And it started as a research tool, as well as now it's used in everyday practice. So how do we actually do this strain that we've been talking about? The first thing I want to say is that image quality is key. Good images, good quality images will most likely produce good strain tracking. You want to be able to optimize your image. And what I like to do is optimize it just like I would to measure an LVEF. So I might decrease my depth to focus on the LV. When you're also doing this, when you're optimizing your endocardial border, you can also optimize your frame rate as well. That can be done by physics, by just narrowing your sector size. You can also increase the frame rate on most machines. You want to have a good ECG tracing. So you want to make sure that those beats are really able to gate, or the software is able to gate the ECG really well. And you want to record up to 3 beats. When I do this, I'll have the patient hold their breath so that there's no translation in the image. And then you wait for your 3 beats and you'll capture an apical 3 and 4 and 2 chamber. What I like to do when I'm acquiring these images is I'll usually take them at the beginning or end of my apical section of the exam. This allows me to, one, look at all my images in a row so I can find them, but then it also makes sure that I have similar heart rates. If you don't have a same heart rate, the software might not track as well. And when you're looking at the frame rates of these images, you want them to be about 40 to 80 frames per second. Some of the softwares will not track these images if they are lower than that. So like Dr. Thomas was saying, there's so many systems now that are just automated. So you'll pull up these images and it'll draw an ROI, or a region of interest, for you. Now, if you don't agree with this region of interest, you can manually change it, or you can use a semi-automated approach like a 3-click method, and that'll be something that is through all of the vendors. When we place our points, usually we can start with whatever image we want to. I like to start with a 3-chamber, and we're gonna place 3 points, one on the basal posterior segment at the mitral valve annulus insertion right there. The second will be at the basal anteroseptum, just proximal to the LVOT, and then the third will be at the apex. That way it'll draw a line, just like this, it'll draw the ROI. And this example, I'm using GE EchoPack, so it might look a little bit different from your system, but most of them work the same. The ROI will be drawn, and you can actually adjust those by clicking and dragging the inner line of those dots until it fits the LV wall. You can also adjust the wall thickness as needed because of patients that have significant hypertrophy. You want to make sure both the endocardium and the myocardium are included within the lines, but you want to exclude the pericardium. Once you have that all set, you'll hit process. So then it'll analyze your strain. This is just for the one view. So this is my 3-chamber view, and we'll get what's called a quad view. On the top left, it'll show you kind of the single view of the cine loop. And this is to inspect the tracking to make sure that that line is really tracking the way that your ventricle is moving. The bottom left will give you a segmental strain breakdown showing the peak strain values. And each segment is color coded, and you'll see those same colors over on the top right in the strain curves. This is the strain curves for the 6 segments, and then you'll see a dotted white line, which is the global strain for that view. The bottom right is the M-mode strain map, and so you'll see the cardiac cycle over time at the bottom, and then you can also see the segmental breakdown as well. We're going to move on to our next image. I'll pick a 4-chamber, and we're going to do the same thing. So 3-click method, you're going to plot your points at the mitral annular insertion points, and then at the apex. Once again, you'll get your quad view showing your strain cine loop and the curves. And then again, we're going to do just the same old thing, follow the drill. We're going to place our 3 points at the mitral valve insertion, and then again at the apex. Once you plot those points, again, you'll have the ROI drawn for you, and you can adjust that if needed. And you'll just have to approve that to get your strain curves. On the GE EchoPack, the bullseye, if you've approved all 3 views, the bullseye and the GLS is now available. You'll see the BE and traces, which is bullseye and traces, and that'll show you this view that I have up on the screen, and that'll show you all the strain curves plus the bullseye. I like to look at this because it gives me a good look at what the GLS is by looking at the bullseye, but then it also allows me to visualize the curves to make sure that my strain was actually tracking all right. So strain curves uncovered. We look at these and you say, what the heck are all those lines, squiggly lines doing? But basically, these strain curves follow the cardiac cycle. So you'll see the ECG there at the bottom, and the segments are color-coded. And then we want to see in systole, the muscle is going to shorten, so the longitudinal strain goes down. So the muscle is shortening, and then in diastole, you see it go back up, it elongates and relaxes, and you'll see it go back up to the baseline. We also see atrial contraction, and then the colors represent those segments. The final step is the big bullseye that we see. And in GE EchoPack, the peak segmental strain is on the bullseye. So each of those little red squares in the circle is one of the segments. And those are the averages for each view. The global longitudinal peak strain average, which is this 4th number at the bottom here, is the number that we'll report, and it's the average of all of those segments. Now, different vendors may have different approaches to this peak segmental strain on the bullseye. So some may use end systolic strain, peak systolic, or peak throughout. The software may allow you to pick this option in the configuration, but it's just depending on the vendor that you have. Now, so to review some of those important points, before we go into some troubleshooting, we really want quality images. Quality images will give you quality tracking. And if you have poor images, that may be the reason why your strain is not tracking as well. Most of these software packages will guide you what to do. So if you forget one of these steps, it should give you a little hint saying, place this point here or approve this here. You want to make sure that the software and your eye assess the tracking. Sometimes we can get carried away with the automation in a world of 2019 and everything's automated, but we want to make sure that our eye actually agrees with the tracking as well. And if it does make sense, that's great, but if it doesn't make sense, don't report it. Now we've talked a little bit, or I'm sure everybody's heard a little bit about RV strain, and we'll be hearing more about it later. But to acquire this image, we want to have a focused RV view with visualization of the RV free wall. I find most helpful to go a little bit more lateral on the patient. This way I can kind of take out the LV almost from my image and just focus on that RV. Some vendors have dedicated RV strain, and so you can use that package, or you can trick the software with using the apical long axis or 4-chamber tracking. And what we want to report, we're going to get these 3 segments along the free wall, and really for now that is all we're looking at, and we're going to report that free wall value as an average. So what do we do when things don't go right? You know, you might have something that doesn't track the endocardium, or the strain curves look a little off. What do we do with our technically difficult patients, or if we have low or positive strain numbers? And I'll be going through a few cases just to show you some of those. So my first case is a 54-year-old male with aortic regurgitation. And we see from his images, he's got pretty good systolic function, and his global strain average was minus 22.4. So that's normal. We look over here at the strain curves. These all look pretty good. So should we just call it a day? I don't think so. The image quality was not what we wanted it to be on this patient. When I slid down a rib space, we can see we really elongated and avoided foreshortening in this patient. And the image quality is really crucial. So with redoing the strain, we got a GLS of minus 19.7, which is still normal, but it is a little bit lower than we did with those foreshortened images. So they may give you, a foreshortened image may give you a higher strain value than is actually accurate. And really when you're tracking these patients over time, or like Dr. Thomas said, before a valve intervention, these strain numbers may be really important to their outcome. Our second case is a 53-year-old male with hypertension, and we can see he's got pretty significant hypertrophy. After we calculated the strain, his strain was minus 14.8%, which is abnormal, which I kind of figured for somebody with this amount of hypertrophy. But when you look at the actual tracking, and I don't have these playing, but if you look at these red lines, you see it doesn't quite all the way go around the endo and the myocardium. So in this case, I adjusted the ROI, increasing the width to really encompass all of the heart muscle and the wall thickness within that ROI. And our GLS dropped to minus 12.8, which is still abnormal, but we really want to make sure that we're reporting these accurate numbers. Case 3 is a 69-year-old female who presents with shortness of breath and a concern for PE. When we look at these images, we see she's got very normal LV function, but then when we calculated her strain, her GLS was minus 13.7. So let's see, if I have a low number, I'm looking at this, the strain looks like it's tracking okay. I know these aren't very large, but it looks like all of the segment or the curves are going the right way. And then we look at the bullseye and we see a little bit of red, but mostly pink. And now that I've checked everything, I've checked that my ROI was tracking and my strain curves looked okay, this is real. So strain can really help us uncover underlying heart disease and add diagnostic information to the LVEF. So this patient was diagnosed with heart failure with preserved ejection fraction when she was admitted. This also tells us that we just really need to understand the curves and the colors when we're looking at these strain maps to make sure that we're getting accurate results. Case 4 is a 72-year-old man with HFpEF who presents with edema and worsening heart failure symptoms, and we see he's not really HFpEF anymore. And he is an AFib, so can we do strain with AFib? And the answer is yes. What I like to do is use a multiplane imaging, usually with the 4D probe. And I can do a multiplane so that I can get all 3 images, the 4, 3, and 2 chamber, all in the same cardiac cycle. Most of the time with AFib, the tricky part is that the heart rates are so different that the strain won't track as well. So when I did this with multiplane imaging, I was able to get the strain curves and the bullseye, and we see his GLS is minus 8.3, which makes sense with his EF. But we also see this apical sparing, this brighter red on top, which could be suggestive of cardiac amyloid, which will be presented later in the webinar. Lastly, a 50-year-old female with hypertension shows up, and I wanted to show you this bullseye first. So his GLS is minus 16.2, but we see that big blue streak go down the middle of it. This makes me think that at his anterior septum and his posterior wall, those are going to be dyskinetic. The blue is stretching. We're not seeing that red like it's shortening like it's supposed to. So something's wrong. So then when we look at the EF though, this looks pretty normal. So what's going on? When we look at the ECG at the bottom, we can see that the lines that the gating of the ECG is off of to track this strain is actually tracking this man's very large P waves. So instead of the QRS, it's taking the cycle from P to P wave. And so be aware that it can trigger off of those if they're very large. Now, we went back and did it manually, and so that we could track it off of our gating. And this bullseye looks a little bit more normal. The GLS was minus 14.5, which is abnormal, but at least it's looking all red and a little bit more normal. So we really want to make sure we trust our eye. So looking at ejection fractioning and looking at that blue streak, thinking to ourselves that doesn't make sense, and redo it if you think it's off. Another reason why you should understand the curves and the colors so that we can appropriately track our segments. And then you may want to try a different image or even other software if you aren't getting the result that you want. My last piece of troubleshooting advice is for technically difficult patients. Sometimes we just can't get the pictures to track. I usually just have a colleague or somebody else come and try to get those strain pictures if it's really necessary. But with speckle tracking, echo-enhancing agents do not work with them, at least right now. Hopefully in the future, our strain vendors will be able to track a little bit more. But as of now, these softwares are not able to do that. And so with our technically difficult patients, sometimes I'll just put a caveat in the report that the images were too technically difficult to accurately calculate strain. So if you have garbage pictures in, you're gonna get garbage out. So ASC is connected to a lot of different vendors, and all of these vendors have a strain package for you. So whatever you have at your institution, please make sure to check with your vendors, as they'll have very vendor-specific things for the different applications, and they can give you more tips and advice for each strain software. Some of these will be vendor-specific, so like GE can only read GE images, but then also other ones may be vendor-neutral that could look at all of them. So thank you, and I will leave it to some question and answer.
All right, thank you so much, Maddie. Come back and join the table. And Akil, do we have any questions that have come in?
Absolutely, we have several questions to start out with regarding the physics and acquisition. I'll leave it to our panel to address. The first question, a few questions are regarding the reporting requirements to be reimbursed for strain. Are there specific things that need to be included in the report in order to bill for that code?
I don't know exactly what needs to be included, but I think you need to state that strain imaging was performed, and you need to state something about it. That's something, the easiest thing is just to report a global longitudinal strain, but as you'll see, there are some specific patterns that are also very helpful in making diagnoses. So if you comment on that, I can't speak for CMS, but I'd give you your $8 for doing that.
Wonderful. And then regarding the strain reports from retrospective studies, do we need raw data in order to do this, DICOM data, compressed data? What's the minimum frame rate if you want to pull studies retrospectively to be able to report strain, or at least do measurements for strain?
Maddie, you want to tell us how you can do retrospective strain measurements?
Is this on? Yes.
Yes.
Okay, perfect. Usually you can do it as long as you have an offline vendor, and as long as the frame rates are between 40 and 80 on your images that you took originally, you should be able to do it. I think the caveat is maybe just the making sure the image quality is there, you know, retrospectively. Obviously, it's easier prospectively, because if you can't track something, then you can just retake an image. So I think that's something that is good to think about.
It certainly can be done offline, and you know, even a lot of times check your ecosystems, because a lot of times you will be capturing images at 60 frames per second, but your IT gremlins have set the send rate from that cart to 30 frames per second. It'll go out at the video frame rate. You need to send the full ultrasound frame rate, or you won't be able to get accuracy when you do your offline strain measurements. Roberto, any other comments on that?
No, I would agree. Another key word is to make sure you say the native data. It's another word that people use in order to preserve the frame rate.
Okay, what else? Akil?
A little bit about atrial fibrillation or ectopy. There are some thoughts or comments from the audience about averaging strain over multiple heartbeats. I wanted to get the panel's opinion on averaging strain rates in atrial fibrillation, or if patients have bigeminy, how you would deal with those situations as the systolic diastolic function might change from beat to beat.
Oh, well, as usual, AFib ruins everything. So you are going to have some variability there. And I think there are a couple of ways to do it. First of all, the software won't let you form a bullseye unless your RR intervals are pretty close together. Now, Maddie showed the way of guaranteeing that they're close together by gathering it in a triplane view, so it's the same beat. And I think, you know, I will generally go for a beat that is neither a very long RR interval or a very short RR interval, but kind of in the, you know, the Goldilocks phase of the RR interval. Nausheen, you have to deal with a lot of patients in AFib. Do you have any hints on that?
No, I think that Maddie's approach is the best approach, and to try to get the cumulative RR with one acquisition, probably the best approach.
Okay, time for a couple more.
Yeah, a few other technical questions. If you have great images except for maybe one or two segments like the apex, how do you deal with that? Do you eliminate those single segments and report the strain for the rest of the myocardium, or do you not report that at all if you're not able to really get ideal images perhaps in one of the views?
Roberto, what do you do when you get an X on there?
Yeah, I think probably a good way to do it is if you have at least in one view 2 segments in which the strain is not reliable or not tracking, you probably should disregard that acquisition.
And make sure you look carefully and be sure you don't have a situation like Maddie showed where it's actually triggering off the P wave and you get a big stretch, which is actually just atrial contraction filling the ventricle there, because some of the strain packages will take a positive peak in preference to a negative peak and report that. And sometimes if there really is a little bit of a stretch at the start of systole there, you can kind of just take that number out and then average in where the negative one actually is there. So you can play with a little bit, but it's always good if it actually shows the expected curve shape. Maybe one more, Akil?
Sure. Another technical question: when you're performing strain in patients with left ventricular hypertrophy, how much of the myocardium, epicardium, endocardium are you including in your tracings in adjusting the width of the box for strain?
Maddie, take it away.
I think it really depends on the vendor that you're using. There are some vendors that you're able to adjust the ROI, and there are some vendors that it depends what they're tracking. I know working with TomTech, they do a endocardial tracing, so you cannot adjust the ROI width unless you're doing it a manual way. As in GE, like we saw, you are able to. I like to really just have the inner line go around the endocardial border, kind of like you were going to trace your LVEF, and then put it over the myocardium so it has a big chunk of that meat, especially in a patient with hypertrophy or HOCM. You want to make sure that you're including most of that wall thickness if you're able to adjust the ROI width.
All right, I think we've had some very good questions to start us out with, and now I'd like to invite Nausheen Akhter, who is the head of our cardio-oncology group at Northwestern and a real expert in the use of strain in this entity, to take us through a very useful set of indications.
Thank you very much, Jim. I'd like to welcome everyone from around the world who have joined us today, especially our friends in Australia, who I guess it's a morning with strain for them. I would like to discuss how I use strain in a cardio-oncology clinic. To sort of set the background or the framework for this, for the next few minutes, the American Society of Clinical Oncology put forth a guideline statement in which they ask us to consider which patients are at increased risk for developing cardiac dysfunction. They ask us to consider 3 different time points: before starting cancer treatment, and to consider preventive strategies to minimize risk at that time point, and then during cancer treatment, again, to minimize risk, to consider strategies, what are our preferred surveillance and monitoring approaches, and then after the completion of cancer treatment, what are the preferred surveillance and monitoring approaches. So oncology is asking us to consider 2 primary things: prevention and surveillance. I think that the role of strain in the setting of cardiotoxicity here is very relevant. So I'd like us to consider the role of strain in these same 3 time points. Before the initiation of therapy, we have some information with regards to prognostication. During cardiotoxic therapy, again, with prognostication and research within the realm of prevention, and after therapy, again, with prognostication. So what is the role of strain before the initiation of anti-cancer therapy? This was a very nice study done by Dr. Shura Crosby and colleagues, looking at 450 patients with leukemia and lymphoma that were treated with anthracyclines and followed for 4 to 5 years. They looked at cardiac events, including cardiac death and symptomatic heart failure. Diabetes and hypertension were the primary risk factors, and a pre-chemotherapy global longitudinal strain was independently associated with these cardiac events. They found a baseline cutoff of less than -17.5 was associated with a 6-time increased risk of cardiac events. Another study looked at baseline global longitudinal strain and MACE outcomes in patients with breast and hematologic malignancies. In 158 patients treated with anthracyclines, the pre-chemotherapy ejection fraction was between 50 and 59%, and these patients were followed for 173 days. Their primary outcome was MACE. They found a cutoff baseline global longitudinal strain of less than or equal to 16% was associated with a 4.7 times increase in MACE. What is the role of strain during the administration of anti-cancer therapy? And much of the work in strain and prognostication has been done here. So let's present a case. A 48-year-old female presents to clinic with left-sided breast cancer that is ER positive, PR negative, and HER2 negative. She is diagnosed in April of 2009. She is very anxious and receives an aggressive cancer treatment, including bilateral mastectomy, adjuvant ACT, which includes a regimen of adriamycin, total dose 240 milligrams per meter squared, cyclophosphamide and Taxol, adjuvant post-mastectomy radiation, bilateral implant reconstructions, and starts adjuvant tamoxifen. Unfortunately, 9 years later, she is found to have a new primary at the lateral aspect of her left breast reconstruction. This time, the tumor is ER positive, PR negative, and HER2 positive. Her treatment includes a wide excision, including skeletal muscle with negative margins. She is started on adjuvant TCHP and received 6 cycles. This regimen includes docetaxel, carboplatin, and dual HER2 agents, trastuzumab and pertuzumab. Her baseline echocardiogram demonstrates an ejection fraction of 70% and a global longitudinal strain of negative 20.2%, normal. At her 3-month echo surveillance, her ejection fraction has declined to 58%, and her global longitudinal strain is negative 16.3%. You can see here the strain curves at the bottom of the slide. So this patient does not meet the criteria for cancer therapeutic-related cardiac dysfunction, despite a change in her ejection fraction from baseline of greater than 10%. She does not meet a nadir value of less than 53%. However, there has been a relative drop in her global longitudinal strain when compared to baseline of greater than 15%. And this meets the criteria for subclinical LV dysfunction as described in an expert consensus statement put forth by the American Society of Echo in 2014. What do we do with this information? We are very eagerly awaiting the results of the SECURE study. In this study, they are randomizing patients to EF guidance versus strain guidance, in which patients with reduced strain will be started on cardioprotective therapy. This study has completed enrollment and is in its follow-up period. We are also doing a study here at Northwestern looking at non-anthracycline trastuzumab patients who are HER2 positive with normal ejection fraction and abnormal strain and randomizing them to prophylactic carvedilol versus no treatment. So this patient does not meet a cardiologist. At her 5-month echo, the ejection fraction is now 47% and her strain is negative 14.7%. You can see here the strain curves at the bottom. She endorses dyspnea with stairs, chest tightness. Her chemotherapy is stopped. Carvedilol is started at 3.125 twice a day. Goal-directed medical therapy is limited due to hypotension. A stress test is done at her next ejection fraction assessment due to a history of prior left-sided radiation history in 2009, which demonstrates no ischemia, and her ejection fraction is improved to 50 to 55%. Oncology would like to resume treatment in this patient now that the ejection fraction has improved, and she is re-challenged with a treatment called TDM1, which is adotrastuzumab. It is very similar to trastuzumab, except that it is covalently linked to a cytotoxic agent. The monitoring on this drug is similar to trastuzumab with every 3-month echocardiograms. At her 7-month echo on TDM1, her ejection fraction is 54% with a global longitudinal strain of negative 15.9%. What do we know about trastuzumab cardiotoxicity? In general, we are seeing patients with asymptomatic declines in their ejection fraction, which is much more common than symptomatic heart failure. It is not related to cumulative dose as opposed to anthracyclines and is largely reversible. There are higher rates when used sequentially with anthracyclines, as you can see here in this estimated probability of cardiotoxicity that was done on breast cancer patients. The blue curve represents the doxorubicin plus trastuzumab probability, which is much higher than trastuzumab alone or doxorubicin alone. Is it okay to re-challenge these patients? Yes. And these patients, once ejection fraction recovers on goal-directed medical therapy, can resume treatment for their breast cancer. This is very relevant in our metastatic patient population who are on these drugs for years. On her 11th month echo, we now see that her ejection fraction continues to be normal at 55%, but the strain pattern is quite unusual. She has blue on the outer edges and red in the center. And so this is actually an example of a breast implant artifact. You can see here that the breast implant shadow obscures the basal segments of the heart, which don't track well. The yellow and red curves do not track on the strain curve. We here at Northwestern are very interested in this patient group is very challenging, especially our patients with left-sided breast cancer. And so we devised a subcostal strain protocol. This is a proof of concept study that was published last year in the Journal of American Society of Echo, in which we were able to show that the apical 4-chamber view and the subcostal 4-chamber view strain had good reliability and good agreement, and the apical 3-chamber view and the modified subcostal 3-chamber view had good reliability and agreement. These are the correlation and the Bland-Altman curves. We're now looking at whether or not we can use the subcostal view to monitor for cardiotoxicity and whether the cutoffs from the subcostal view are different than the apical view. Between 2011 and 2013, there were several studies that demonstrated the prognostic utility of global longitudinal strain in our breast cancer population. These were the backbone to the ASC consensus statement document, and what must be noted here is that all of these papers were done very specifically in HER2-positive breast cancer patients that were receiving sequential treatment with anthracycline followed by trastuzumab. This is a nice study done by Dr. Bonnie Key and colleagues looking at 135 patients with breast cancer. And what she shows is that the longitudinal strain changes occur first and that circumferential strain changes occurred second in patients with, who developed cardiotoxicity. Global longitudinal strain is an early predictor of cardiotoxicity and can predate a change in ejection fraction by 3 to 6 months before we see changes in the ejection fraction. It has a very high negative predictive value. This is another very nice study that was done by Dr. Thravindranath and colleagues looking at a meta-analysis of 21 patients. They looked at breast heme malignancies and sarcomas, patients that were treated with anthracyclines plus minus trastuzumab. The cardiotoxicity weighted pool estimate was 21% in their entire cohort. What's interesting is they looked at both an on-treatment absolute global longitudinal strain and a relative change in global longitudinal strain from baseline and found that both of these measures had good performance for subsequent development of cancer therapeutic-related cardiac dysfunction. And I think that this is very important in its practical and pragmatic clinical application. However, they also report a concern for publication bias and that we are publishing only the positive studies and that there's limited data on optimal cutoff values and we need larger prospective trials in this arena. What is the role of strain after the completion of anti-cancer therapy? Again, more data is needed here, but there is some information regarding prognostication. This study done by Dr. Armstrong and colleagues looked at survivors of childhood cancer. They looked at 1,800 adults. Median time from cancer diagnosis was 23 years, and all these patients received anthracycline and/or radiotherapy. 5.8% of survivors had an abnormal ejection fraction. But what's very interesting is that 28% of the patients studied had a preserved 3D ejection fraction and a reduced global longitudinal strain. So what happens to this group is quite intriguing and something that actually we're looking at here with Dr. Vera Riggelen. Post-treatment global longitudinal strain predicts left ventricular recovery in breast cancer. So recovery can also be, strain can also be useful for assessment of recovery. And this study, done on 95 patients with breast cancer that were treated with anthracycline and trastuzumab, they found that 20% of patients developed cardiotoxicity, and of these patients, the LVEF was partially or fully recovered in 68%. But what was most helpful was the global longitudinal strain at the time of the cardiotoxicity diagnosis that was associated with subsequent LVEF recovery. The higher the strain at the time of diagnosis was more likely, you were more likely to see recovery. And to summarize, I use strain in the cardio-oncology clinic primarily for prognostication. In the pre-chemotherapy setting, global longitudinal strain may have discriminatory ability to identify patients at risk for cardiac dysfunction. Strain can also be trended for prognostication of LV dysfunction during treatment in patients with breast cancer, but may be useful across cancer subtypes with anthracyclines plus minus trastuzumab. And in the post-chemotherapy, global longitudinal strain may be used for prediction of LV dysfunction or recovery, but more work is needed here. With regards to prevention, prophylactic medication based on a strain surveillance strategy is currently being studied, and hopefully we'll have the results for this soon. Thank you.
Thank you so much, Nausheen. That was a very comprehensive overview of how we can use this. And now a man who really needs no introduction, even though I've already introduced him, Roberto Lang, my comrade in arms on many trips around the world, and he is going to talk to us about applications of strain in coronary artery disease and also in heart failure.
Well, thank you for inviting me. I want to thank ASC and Jim for putting this together. So when we wrote the guidelines in 2015, we didn't have normal values, as Jim was pointing out. So we actually were very diplomatic and said that the global normal GLS would be in the range of minus 20%, and we were not too bad. We definitely talked about the need, was very nicely described, about optimizing image quality. I think it's very important when we think about strain in coronary artery disease, we need to have and take into consideration the fiber orientation of the myocardium. And in this, the most important thing to remember is that in the subendocardium, the fibers are longitudinally oriented. When we go more to the mid, the fibers are oriented in a circumferential direction. And when we go more towards the subepicardium, these are oblique. So you have to understand that the subendocardium is actually responsible for the longitudinal strain. And when we have myocardial ischemia, usually the subendocardial fibers are primarily affected. So that's why in coronary artery disease, primary longitudinal strain is so important. The mid-wall fibers that have more of a circumferential orientation are mostly affected when there is transmural ischemia. Regarding coronary artery disease and strain, I think it's very important that we start with an apical lung and we get a very accurate timing of aortic valve closure. When we put a region of interest, we want to avoid the LVOT. We want to avoid spilling into the left atrium. We want to avoid, and this was already asked, to have a very wide region of interest. And also we want to avoid foreshortened images. Now, coronary artery disease and strain can be very nicely used, and this is very developed across the world. Though this looks very advanced, this is not the University of Chicago, and this is not at Northwestern, but this is in Argentina in the lab of Dr. Lowenstein, who has worked with strain for a very long time. When you talk about coronary artery disease and strain, I think there were 4 things I would like you to remember. We will talk from now on a lot into the patterns. And in the Cleveland Clinic and with Jim Thomas here, they were the first to describe this cherry on top that we all use in order to suspect cardiac amyloidosis. The same pattern recognition can be used to assess coronary artery disease if we take into consideration the coronary artery distribution. This is a normal patient. You can see how the ventricle is moving nicely, and we see that in this patient with normal coronary arteries, we see that the strain is uniform across all the regions. But if you take a patient with infraposterior and lateral ischemia, which you can see in the 2D echo, you can see that they have lower strain in that particular region. So recognizing these patterns is very important. This is a patient with septical, apical, and anterior hypokinesis. This is very nicely seen, and again, demonstrated by the regional strain. So recognizing these patterns of an LAD, a RCA, or a circumflex lesion, I think is going to become very useful. We're going to start using this more and more when we do stress testing. Now, what happens to strain 3 minutes post-stress? So let's take a patient that starts with a normal, uniform, minus 20% of longitudinal strain. He has a positive stress test in the apical, septal, and anterior and inferior segments. The strain goes down to minus 13%. And for a while, it was thought that strain would retain a certain memory. But if you do this 3 minutes into recovery, you can see that the strain has recovered completely. So this issue of a memory does not exist. I think there are many, many studies now that show us that in patients that have normal wall motion abnormality without any regional wall motion abnormalities, the longitudinal 2-dimensional strain can predict the presence of a left main and 3-vessel coronary artery disease. So that's something that I think is very important to remember. So we talked about the patterns. Let me remind you about a new pattern. In patients that have ischemia, if you have a line of where the aortic valve closes, you can see that when there is ischemia, the ventricle continues to thicken past the end of systole or past the moment of aortic valve closure. And this is called as post-systolic thickening after acute ischemia. And the interplay of why this happens is complex, has to do with the intraventricular pressure. It also has to do with the elasticity of the tissue. But if you look at a patient, and this is done with a balloon in a coronary artery, you can see with occlusion that the strain is reduced and the thickening progresses post-aortic valve closure, and on reopening of the balloon, it actually returns to normal. The third thing I want you to remember in coronary artery disease is this, what is called this index of mechanical dispersion. If you take care and the machines, the software do it, if you actually look at the standard deviation of each of these regional strain curves, the time of the peak of each of these 16 regions towards the closure of the aortic valve, this distance, and you average and obtain the standard deviation, and you express it as a percentage of the RR interval, then you can look at that as an index of dispersion. For example, let's take a patient here. This is a patient that has 2 severe lesions in the LAD, strain obtained at rest and at stress. And you can see that at stress, not only that we see this post-systolic thickening, but you see that the contraction becomes much less uniform. The index of dispersion is increased. And that is very nicely seen in stress, so we can look at these types of combinations. This mechanical dispersion has also been used to try and separate healthy athletes for athletes that have hypertrophic cardiomyopathy. You can see in the healthy athletes how uniform it is, and in the athletes in the hypertrophic cardiomyopathy, you can see this index of dispersion. Now, people have tried to combine. If you combine in patients post-MI, the combination of the longitudinal strain and the mechanical dispersion, people have found that independently of the left ventricular ejection fraction, this data can aid into which of these patients will require to have an implantable cardioverter. So you can sort of get an idea of which patients will have arrhythmic events. So in conclusion, I would like to be very optimistic that strain aids in the detection of coronary artery disease. There are many studies showing that the lack of improvement in GLS after coronary revascularization is associated with negative left ventricular remodeling. And in patients with acute MI, strain and strain rate were significant and independently correlated with all-cause mortality, reinfarction, and revascularization. Just 2 words about strain and heart failure. This is, again, another situation in which strain is extremely useful. It can be used for risk assessment. It can be used for the diagnosis. It can be used for management, particularly with CRT and VADS. And again, cardiotoxicity as have been used. This is an example of a study that we did in which we actually used 3-dimensional longitudinal strain in patients with reduced ejection fraction. It adds value in stratifying the outcomes. So we're going to leave 3D for another time that Jim will organize in about maybe 1 or 2 years. How can we use it for the etiology? Well, by looking at these patterns, we can recognize causes of heart failure: amyloidosis, hypertensive heart disease, and hypertrophic cardiomyopathy. Let me talk to you a little bit about, look at this longitudinal strain now in a normal subject on top, and in a patient that has a complete left bundle branch PROC. And you can see that there is these regions that do this peak early strain that is followed by this lateral wall peak strain. So it's actually very useful to look at the uniform of contraction. And again, of another study in which people are now trying to do his bundle pacing, you can see at baseline that this index of dispersion is extremely wide. And after 6 months of bundle his pacing, you have almost a complete recovery of the uniformity of contraction. Just a little glance of all the things we can do with strain in coronary artery disease. Thank you very much.
All right, thank you, Roberto. And now we're going to open the lines up for more questions, and I will tell our live audience here, if you all have any questions, please come up. I think we have a microphone here, and but in the meantime, let's get started. Akil with one there.
Sure, several questions on cardio-oncology and the use of strain, and also for patients with coronary disease. The first question is, if you could comment on your understanding of the impact on preload on global longitudinal strain, since a lot of the cardio-onc patients have changes in their preload as part of their chemotherapy with volume loading, and also how you can comment on the impact of blood pressure and afterload on strain as well.
This is a very important point and question. Preload as well as afterload do affect changes in strain. We will report blood pressure on all of our echo reports. If there is a change in strain that we think may be related to changes in preload, both a reduction in preload and an increase in afterload can reduce strain. So if we think that this might be in play, then it's important to repeat the echo and strain when the patient, when the hemodynamics are better.
If I can just add one thing, this is a real thing. We published a paper last year in JACE from some of our NASA work analyzing astronauts before they went into space, just doing a tilt test on them, and the reduction in preload from going from horizontal to near vertical reduced their strain from like -19 to -14, 15. So it's absolutely sensitive to preload. I would say maybe less sensitive than some of our other measurements there. But certainly in the cardio-oncology world, I would want to have a repeat measure at a time when you know they haven't been, vomiting and things like that, and are in a good fluid status there. And obviously, if you increase your afterload, you will also decrease the strain. That's one of the things we see in aortic stenosis.
One more cardio-oncology question. If you have a patient, hypothetically, that has a normal ejection fraction but abnormal strain prior to beginning a cardiotoxic chemotherapy, what's your clinical approach to these patients in terms of serial echocardiograms to follow strain and also initiation of therapies like beta blockers, ACE inhibitors?
If the patient is already on blood pressure agents, that is something to consider, to perhaps switch them over to blood pressure agents that can also be used for cardioprotection, such as carvedilol or ACE inhibitors. It's very important that these patients' blood pressure is well controlled before starting treatment, and so that is an area that we can intervene on pre-treatment.
And then in patients with coronary disease, often when we do strain measurements at rest and after exercise, we have to use contrast. So comments on the applicability of global longitudinal strain measurements in contrast.
We actually did 2 studies, and I think meaning we, just by changing the settings and the way that you give contrast, you can sort of get an idea that this will be possible. It's up to our vendor companies to try and put the effort to be able to do it, but I'm very optimistic that that will work.
You might imagine that the ones that are tracking the endocardium would have more success because there are, little trabeculations that they can kind of hang on to, whereas when you're really tracking the thickness of the myocardium there, you really depend on speckles essentially staying in the same place or moving with the myocardium as it contracts there. Whereas the nature of contrast is it's a new contrast field every single frame. Stuff is moving through there all the time. But tracking features in the endocardium may be a way around this. But be cautious.
You're absolutely right, because when bubbles get trapped somehow, I don't know if that is the correct word, in the endocardium, it's when so you use very little contrast, but we'll see.
And if there could be some comments on the applicability of strain in transesophageal echocardiography, understanding there's limitations with sedation and preload on those patients as well.
It can certainly be done, and I did a study at Cleveland Clinic where we looked at strain before and after bypass grafting, and with Andrea Duncan, and it is certainly feasible. Now, you often don't get quite the same coverage of the ventricle that you do from the chest wall, and you're working a lot in the far field with relatively high frequencies. So I don't think there's a lot of experience with this, but it certainly can be done. And I would guess to the extent that you're getting the curves, you would have relatively similar normal ranges there. Roberto, have you ever tried this?
Yes, but I mean, I agree with you 100%. I think the apex is obviously the difficulty with TE, right? Many times we don't get truly, and if we do, many times we have to foreshorten, so. Yeah.
You have much less freedom of movement when you're confined to the esophagus there. Some others?
Yeah, there's a couple questions that came up on the role of strain in speckle tracking and diastolic function analysis.
Well, I mean, it was something that we are not going to touch today. It's always good to leave something in suspense. Is the fact of I think that there is quite a lot of potential use for left atrial strain. And I think there are many papers really have shown that, strain, the shape and the values of shape change as your diastolic function is reduced. And I'm sure that strain will be included in the left atrial strain will be included in the guidelines next time around.
And there's been some work done with diastolic strain rate for left ventricular strain, and when that's depressed, that can be indicative of diastolic dysfunction. And in situations where you're sort of wavering between normal or pseudo-normal and your parameters are close to the cutoff values there, if I see a strain of -21, I feel pretty good about it. If I see a strain of -14, I'm thinking there's more significant diastolic dysfunction. But agree completely, the atrial strain looks very promising. I almost put it in this, but I thought that was just a little too much to bite off in a 2-hour seminar. Any more there, Akil?
The next question was, in patients you are following strain for, either in cardiotoxicity or other disease states, if you have a multi-vendor lab and are acquiring images with different platforms on cart, how do you resolve these differences? Or do you do it all offline or request that the same vendor be used for subsequent measurements?
We do use the same vendor in our lab. So we try to do all of our cardio-oncology echocardiograms with the same vendor, as well as in our satellite hospitals, so that we're able to compare between studies if the patient has them done at our hospital. Sometimes if the patients come in with echoes from elsewhere and the strain hasn't been obtained, then we will do the strain using offline software, but this is cannot be directly compared.
Can I ask a question to Jim? So you showed beautifully that the inter-vendor difference is 2%. Nowadays, do we really need to do a patient with the same vendor? More considering that we follow ejection fraction, and ejection fraction seems to have a larger variability.
Yeah, I think that's an excellent point, Roberto, is that there really is good inter-vendor agreement here. I mean, there is some retest variability that you'll see with any test there, but one of the things that we've done in our lab is we will do a measurement on the cart, and then we will also do it offline with a different vendor, just so we kind of gain confidence that, yeah, they really do fall pretty close to each other. And when they don't, you can usually see that there's poor tracking or something like that. When both of the software packages are happy with what they're reporting, they generally come out pretty close to each other. Sure, if you have the option of doing it with the same vendor, that takes away that small issue of variability. But I tell you, if you're following posterior wall thickness, you probably need to measure that with the same vendor if you're really going to apply these rules across the board, because there is inter-vendor variability for all of these measurements that we've never even thought to question in the past. All right. I think maybe now we should move on. We've got 3 more rapid fire presentations to go on valves, the right ventricle, and pediatrics. Hopefully Biff has a St. Bernard and a hot toddy to keep him warm in the snowstorm there. And I will start out with a brief presentation on using strain in valvular heart disease. All right, here I am. So applications of strain in valvular heart disease. Now, what do the guidelines say? Now, let's go back to the last big guideline update in 2014. So in the 2014 valve guidelines, of which I was a member, there were 104,645 words in that guideline. Number of times strain was mentioned, 4. Number of strain references, 2 out of 939, and those were both my references that I shoehorned in. And the number of guidelines that actually used strain, 0. And I'm hoping that after you hear this next little presentation, you will insist on some strain markers in the next edition of the guidelines. Now, let's start out with a case. Here's a 61-year-old man with severe AS, known AS for a couple of years, claims to be asymptomatic and is still quite active. I mean, you can see this is really severe. Pressure difference gradient of 151 over 101 millimeters of mercury with a valve area of 0.7, a little bit of AR going back there, which probably augments the gradient a bit. But he says he's asymptomatic and his LV looks pretty good there. And the general teaching in the past has been not to operate on the asymptomatic patient with AS and normal LV function. As Dr. Brownwald has taught us, the leading cause of death in asymptomatic AS is premature surgery. And you know all the indications for intervention in aortic stenosis. It requires either symptoms or a reduced ejection fraction to get into the operating room with a grade 1 level of recommendation. But think about it. Should it matter if your strain looks like this with a nice deep red GLS minus 24.7%, or like this with a kind of patchwork quilt of pinks and light reds and a global longitudinal strain of minus 13%? And I would contend to you that this should be factored into your thinking. Here's some work from Cleveland Clinic, where they looked at 531 patients with valve areas less than 1.3, LVEF greater than 50%, and looking at survival. And you can see that strain was a very strong predictor of survival here. And if the strain was below minus 11.6, that had a very poor prognostic sign here. And in fact, when they compared this as a prognostic indicator versus symptoms or versus STS score, the strain trumped both of those parameters. Another study that came out just last year from Euro Bax's work and looking at several different centers around the world, These were all patients with asymptomatic severe aortic stenosis, and looking at the natural history of global longitudinal strain and its prognostic implication here. And of course, over time, we anticipate mean gradients to go up, LV mass goes up, ejection fraction stays about the same. Global longitudinal strain went down very significantly over the course of this study, and their dichotomized line at about minus 18.2% really separated out very significant differences in survival and event rate among these patients. And I was asked by Bob Bono to write an editorial for this particular paper, and I closed with the statement that perhaps it is time to organize a clinical trial of asymptomatic severe aortic stenosis with randomization between those whose care is guided in part by GLS and those using current guidelines to time intervention. Now, this is a situation that we see at least once a month in our TAVR workups. Here is a 91-year-old man with dyspnea and a question of low flow, low gradient AS. And you can see he's got a thick walled heart. It isn't contracting very well. The sonographer dutifully measured a peak and mean gradient of 45/24 millimeters of mercury. But it was this beat. That is a post-PVC beat. It is not representative of the average gradient that he showed, which was more like 32/18, so really low gradient there. And then we turned on his strain, and here's what we saw. You've heard it mentioned a couple of times. It is the classic apical sparing pattern here of where the apex, in this case, was 7.4 times the ratio of the rest of the heart here. And this all was developed out of a paper that I wrote with two of my old imaging fellows, Dermot Phelan and Patrick Collier, at Cleveland Clinic a few years back. And you can see the very consistent pattern on the top row here of these patients with apical sparing versus patients with hypertrophic cardiomyopathy and patients with hypertensive heart disease from aortic stenosis. And we have termed this the cherry on top of the ice cream cone sign, where the apex is more than twice the rest of the ventricle there. If you see that, think amyloid. It's not always going to be true, but it will be true more often than you will believe. It's a surprising thing. So this man had a strong suspicion for amyloid, confirmed with a pyrophosphate scan, and he was deemed not a good TAVR candidate at that point. And just to show a few more of these patterns here, this is courtesy of Nausheen, who we published this paper earlier this year, just to show a few of these kind of pathognomonic patterns here of apical hokum with low strain at the apex, Takotsubo with apical ballooning here, and then reverse Takotsubo, which looks a little bit like amyloid, but this is just hypokinesis at the base of the heart that then recovers in follow-up, as you can see there. Now, what about mitral regurgitation? Remember, we're talking about organic mitral regurgitation, where the valve makes the ventricle sick. You can see this nice flail posterior leaflet and really severe anteriorly directed mitral regurgitation. Now, this is a study I worked with Jeroen Bax almost 10 years ago, and we looked at a whole host of parameters to try to predict which patients would have an ejection fraction less than 50% 12 months after surgery here. And you can see we looked at AFib, symptoms, ejection fraction, size of the ventricle was significant here, but the most significant measure of all was global longitudinal strain, less than minus 19.9. Now, 19.9 is well up into the normal range. It is like a hypernormal range, but because of the pop-off effect of mitral regurgitation, you need a hypernormal GLS as well as ejection fraction to have confidence that you won't get LV dysfunction in the post-op phase. Here's another study from a group of heart centers led by Patrizio Lancelotti here. And you can see there is a strong correlation between GLS and brain natriuretic peptide, and also a real dichotomization at about -20%. Again, a very normal range in most patients, but with severe MR, this is abnormal. If you see a -19, get a little bit nervous. And then a very nice study, long-term study from Korea, 10 years, and showing that GLS adds much more to your predictive accuracy than ejection fraction in this case. And again, when they dichotomized at -18, a real separation for cardiac events. And again, I guess I get asked to write a lot of editorials here. This one I said, regardless, the bulk of the evidence indicates that GLS is useful in MR patients, and practitioners are encouraged to measure this parameter on a routine basis in patients with severe MR. Now, just a word on aortic regurgitation. It's a similar situation to what we've seen before. This is some work out of Cleveland Clinic here, and you can see not quite as dramatic a difference in the separation of these curves, but you can see that there is definitely worsening with lower degrees of strain, but that this seems to be corrected if you operate on these patients. So this might be an argument for earlier surgery in some of these patients, but we need more data to really understand that. And with that, I'd like to hand it over to my friend Roberto to carry us into the wild and woolly world of the right ventricle.
Thank you very much. So a very quick 10 minutes on right ventricular strain. You know, we all always start our talks on the right ventricle talking about the complex crescent shape of the right ventricle. I think it's important when we talk about strain to understand that we have an outlet conus, which accounts for 20% of the end-diastolic volume. We have a trabeculated apex, and we have also, of course, an inflow tract. Now, when we talk about a right ventricular contraction, we initially have this longitudinal sort of contraction in which the tricuspid valve is going towards the apex. Then we have what is called this bellows effect, the inward motion of the free wall. And then the last part of right ventricular contraction is the bulging of the interventricular septum into the right ventricle during left ventricular contraction. Now, in the guidelines of 2015, we paid quite a lot of attention to the right ventricle, and we came up with a lot of parameters to assess right ventricular function. At the end, in most of the echo labs, we look at TAPSE and we look at the S wave of the right ventricular free wall. Essentially, we're making an assumption and talking about longitudinal motion of the right ventricle, but measuring everything only in one single point. What is new now is that we can do right ventricular deformation. Many vendors have programs that can do it, and how it was nicely described, we actually disregard the portion of the interventricular septum because it's sort of a conjoint between the left ventricle and the RV, and we actually only look at the right ventricular strain, which is divided into 3 segments, which we usually average and come up with a single number. Now, how do we do it? I think it's very important also for 2D echo is, as was mentioned, we need to obtain a right ventricular focused view. You want to get an elongated RV and forget about the LV. The RV should not be foreshortened, and the RV should be positioned centrally in the imaging sector. As nicely described, you want to obtain frame rates that are at least 40 frames. And obviously the easiest way to do it is to decrease the width of the septor and the depth. So I think this is the most important thing, is you see how you move the transducer laterally in order to obtain a right ventricular focus view. And I think this is very important, but you need to understand that when we do an RV focus view, we are not looking at the entire right ventricle. When you look at it, this is the plane where we obtain a right ventricular focus view. So we're missing a lot of the right ventricular outflow tract. I think that's sort of also important, but it makes a big difference. If you obtain the same patient, we did a study, was published in JACE, in which you obtain all of these parameters in the typical four-chamber view and in the same patient in the RV focus view. It makes actually a change. All of these parameters, the free wall longitudinal strain, the dimensions, the TAPSE, and the S-wave are all higher when you do it on the RV focus view. So I'd like to sort of encourage everybody to use the RV focus view. This is just an example of one of the vendors showing that you just need to present an RV focus view, and immediately it takes just a couple of seconds and it will provide you with the RV focus measurement. In the guidelines, the same as we did with the left ventricle, we said that around minus 20% is generally in the normal view. And now I would like to convince you why we should use right ventricular strain. So let's assume that I measure the S-wave of the right ventricle and TAPSE, and in the same patients, I actually measure the right ventricular ejection fraction using MRI. And I draw these lines of the normal values of ejection fraction of the right ventricle, and then I put a normal value for the S-wave, and I put a normal value for TAPSE. And then you can see that there is a whole group of patients for the S-wave or for TAPSE that don't match. You have a lower ejection fraction by MRI, but you have a very higher value of the S-wave or of TAPSE. So that is definitely a problem. In which patients that happens the most is, interestingly, in those, and if, again, like Jim was saying, we don't want to do this, but you can see that right ventricular strain correlates very nicely with the right ventricular ejection fraction. And as soon as you have moderate or severe TR, the S-wave and the TAPSE become unreliable, particularly in those patients in which you want to make these measurements, because the MR creates longitudinal motion of that particular point of the right ventricular free wall. Let me show you an example. Sometimes 2D measurements are just wrong. So look at this patient here. Dilated right ventricle, severe TR. TAPSE is 1.6, the S-wave is 14. They look totally normal. But if you look at the MRI of that particular patient, you can see that the right ventricular ejection fraction is low at 27%. And when you do the strain, is minus 13. So if you actually use this, you can see that you can get a very good idea of knowing the strain, what the CMR right ventricular ejection fraction is going to be. So I'd like to finish by telling you that TAPSE and S-wave only correlate moderately with CMR. And when you have moderate or more TR using TAPSE and RVS, you're going to go wrong. RV free wall longitudinal strain correlates much better. Let me show you this patient with pulmonary hypertension. And these are two echoes obtained 1 year apart. And you can see that in this particular patient, the right ventricular free wall strain went from minus 18 to minus 11. But if you look at the S-wave, 1 year apart, there is absolutely no change. And if you look also at the TAPSE, there is absolutely no change. So I think, and in many studies, this is a study from the Mayo Clinic, in which we see again that the right ventricular longitudinal strain of -15 correlates very well with all-cause mortality in these patients. So just to conclude, right ventricular free wall longitudinal strain correlates better with CMR than TAPSE or the S-wave. Right ventricular GLS has prognostic value in pulmonary hypertension. And then these are two actually very interesting studies in patients that have heart failure with left ventricular systolic dysfunction. Abnormal right ventricular GLS was predictive of adverse events after adjusting for LVF and diastolic dysfunction. And in patients undergoing transplant, right ventricular free wall stress was more strongly associated with future cardiovascular events than the left side longitudinal strain. So I'd like to leave you with a message that I think that right ventricular free wall strain is probably going to be the easiest and most accurate way to quickly assess a function of the right ventricle. Thank you very much.
Yes, we can applaud. That's all right. Thank you, Roberto. That was fabulous there, and I agree completely with you. We've got a lot of ways to measure the LV, and we're pretty good at it. Strain, I think, definitely adds to it, but we're lousy at the RV. And strain really, really adds a lot to what are some pretty flimsy methods that we've been working with all along here. So now I would like to call out to Denver and see if Biff is on the line. Biff, are you there?
I am here. I hope you can hear me okay.
Yes, we can hear you in the room just fine, and I think that means you must be going out to the world just fine. So I will be your fingers here, and we'll advance either when it seems appropriate or when you say, advance the slide, dummy.
That sounds good. Thank you, Jim. And I want to thank you, Dr. Thomas, as well as ASE for inviting me to participate in this. I had fully intended to make it to Chicago to be part of the live panel, but in the spirit of this being a live webinar, I appreciate that we can use our technology for me to be able to speak a little bit about some of the applications of strain in the pediatric population. Go ahead and advance.
Great.
Disclosures. So first, I want to talk about a few challenges that are unique to strain analysis in pediatric patients, followed by some selected applications for strain in pediatric patients. Next slide, please. So probably the most important conundrum that we face is that pediatric patients have a faster heart rate. And as was mentioned a couple times this evening, frame rates really do need to be a consideration here. The normal pediatric heart rates, especially in neonates, can be very high as 180 to 200 beats per minute. And so the frame rates really do need to be higher than in adults to accommodate for that. And as was mentioned before, if you send your images from the cart to your PAC system and compress the image to 30 frames per second, that can really cause some problems with a heart rate as high as 180 to 200 beats per minute. So at our institution, and our recommendation if you're scanning children would be that you really do want to apply or to transfer your images at the frame rate of acquisition. And why that matters, I just want to do a quick mathematical example here. Let's say you have an adult with a heart rate of 60 beats per minute, and the frame rate was sent over at 30 frames per second in a DICOM image. Well, doing some simple math, 30 frames per second and 60 seconds in a minute gives you about 1,800 frames in 1 minute. And if you divide that by a heart rate of 60, you get 30 beats or 30 frames per cardiac cycle. And you'll have to excuse my my simple artwork here, but by having 30 points that you can create a strain curve on, you can get a reasonable approximation of your peak strain. So let's go to example 2. Now we've got an infant with a heart rate of 180 beats per minute, and we're still using the image with a frame rate of 30. Using the same math, you now have 10 frames per cardiac cycle. And so you can see those 10 points there below the words. And if you were to try and create a curve there, that might be a reasonable strain curve, and you'll say that's your peak strain value. But if you only have 10 frames in your cardiac cycle, it's possible that curve could have gone much lower and you're underestimating your peak strain. So frame rate really is important. Next slide, please. A few other challenges that we face in the pediatric world. Certainly we have smaller hearts, and the typical left ventricular wall thickness may be as thin as 3 millimeters, which might place some challenges on your contouring, particularly if you're measuring endocardial strain. We do tend to use higher frequency transducers in our young kids because we don't need to penetrate quite as far. And not all of the vendors allow you to immediately use their new strain software with their higher frequency transducers. Sometimes there's updates that are required, and there is an ongoing need for validation testing with these high frequency transducers. And then finally, probably important to us is the patient factors. So these patients are oftentimes agitated. They might be an uncooperative toddler. And really this underscores the importance of using your own recognition and knowledge to be able to sense when things are tracking properly and when they may be improperly tracking due to translation artifact. Next slide, please. So really, I'd like to spend the rest of my time talking about some selected applications for strain in pediatric patients. I'm going to focus on Kawasaki disease, a little bit on pediatric pulmonary hypertension, and then wrap up with single ventricle hearts. Next slide. So Kawasaki disease is a systemic vasculitis that affects the heart by causing coronary dilation and aneurysm formation. And it can also promote myocarditis with diminished function. In a study done by Ben Frank and colleagues published in 2016, he found that there was diminished longitudinal strain in the left ventricle in patients with Kawasaki disease during the acute or inflammatory phase of the disease, and it resolved during the convalescent phase. Now, the mean difference in strain between your baseline period and 6 weeks out, which was the convalescent period, was only negative 2.3% for all patients, but this was more pronounced in patients who had a worse baseline strain. And this correlated with an increase in procalcitonin, an inflammatory marker, and did not correlate with the coronary artery Z-score. Next slide, please. So really, I think what was helpful to me is to look at a case study where strain helped inform our treatment decisions. So here we have a 3-month-old boy who was hospitalized with fever, a rash on his trunk, red hands and feet, dry lips, and conjunctivitis. Now, where he was admitted, there was a sepsis workup done, and the patient was given antibiotics for a presumed sepsis. They were discharged after 4 days. 2 weeks later, the patient arrived in the emergency department after an out-of-hospital cardiac arrest with bystander CPR. And a transthoracic echo showed diminished function with an EF of 41%, as well as multiple coronary artery aneurysms. The patient was treated with IVIG and infliximab for Kawasaki disease. Next slide, please. So in this image, just because some of the audience may not see this too often, I wanted to point out some aneurysm formation. You can see on the left-hand video, there's the aortic valve in the middle in a short axis view, and there's a giant right coronary artery aneurysm, nearly as large as the valve itself. And then in the right-hand panel, you can see the aortic valve with 2 giant aneurysms. One is the left main coronary artery, and the other one is in the LAD. Next slide. So after this patient was treated, they had an echocardiogram, and there was speckle tracking analysis, which showed a diminished global longitudinal strain, as well as severely diminished anterolateral, anteroseptal, and septal regional strains. The average global longitudinal strain was minus 11.2%. And based on this abnormal pattern, a CT angiogram was performed. And that showed that there were giant aneurysms, and in particular, there was an unopacified LAD, which suggested complete occlusion. The patient was then taken to the cath lab for intracoronary thrombolysis with TPA, and they continued to receive TPA in the CICU, followed by administration of abciximab. Next slide, please. And so in the ICU, they received abciximab for 48 hours, and after that, antegrade flow was demonstrated by echo in the LAD, and the patient was discharged home. 2 weeks later, that patient was asymptomatic in clinic, and all echocardiographic markers of function had returned to normal, including their strain. And the patient continues now at home on clopidogrel, aspirin, and enoxaparin, which they'll probably take forever. But now they're almost 6 years old and doing well at home. So a really nice case where strain helped inform our decision-making. Next slide, please. Just a quick mention of pediatric pulmonary hypertension. The right ventricular free wall strain has been shown to be a predictor of adverse clinical events in pediatric pulmonary hypertension, both for idiopathic PAH and secondary to congenital heart disease. My colleague here in Denver, Penny Joan, and her co-investigators found that RV free wall strain is decreased in those with PAH who had adverse events with a average global RV free wall strain of negative 18%, compared with those who didn't, who had an average free wall strain of negative 21%. In an ROC analysis using a cutoff of negative 16%, there was 48% sensitivity and 93% specificity to detect those who did have adverse events from those who didn't. The area under the curve was 0.68. Next slide, please. And then I'd like to spend a few slides talking about single ventricle hearts. Single ventricles have unique ventricular geometry, which can preclude many of the traditional echocardiographic measures of function. So we're oftentimes faced with challenges in knowing what to follow over time in these patients. One of the advantages of speckle tracking is that it's angle independent, which can allow for accurate tracking of the myocardium when you have abnormal geometry or cardiac position. So it doesn't matter if you have levocardia or dextrocardia or mesocardia, you can track that ventricle. And strain analysis really can provide an objective measure of function over just subjective eyeball, and it can be tracked over time. This might identify deterioration of function prior to the development of clinical symptoms. Next slide, please. And so in a paper published in Pediatric Cardiology in 2014, Dr. Wu and colleagues evaluated single right ventricles who had a right ventricular morphology, and this is, for example, hypoplastic left heart syndrome, and found these patients have decreased septal and lateral regional strain values compared with controls. And so you can see there in the oval that their septal, which is really what we call the segment adjacent to the rudimentary chamber, and the lateral surfaces both had decreased strain in the basal, mid, and apical portions of the single right ventricle compared to normal controls. Next slide. In another study published in JACE in 2018, Dr. Lin evaluated RV function in patients with hypoplastic left heart syndrome before bidirectional Glenn operation, which is the second stage in their palliation, including measuring fractional area change, strain, and strain rate. In looking at those who eventually died or underwent transplant with a median follow-up of 5 years, those patients had a lower strain pre-Glenn surgery than those who survived. Next slide. And this table really shows that looking at just a cohort or subset of patients who had a normal fractional area change, so one of the more traditional measures defined as greater than 35%, if you look at just that cohort of patients, longitudinal strain rate appeared to be able to differentiate survivors from death and transplant. Although numbers are low, you can see that there were only 7 death or transplant patients in this study, quite a bit lower than the 1,063 patients followed in Jim's study he mentioned on aortic regurgitation. Next slide, please. I just wanted to show here that it is possible to measure RV strain in a hypoplastic left heart syndrome patient. So on the left side, you can see a systemic right ventricle, and you can see that there's a very small left ventricle, which really isn't serving to do anything. And you can get a nice strain map of the free wall as well as the septum. In this patient, the peak strain is negative 22.2%, for an average, and that's normal for these patients. Next slide. Looking at single ventricles of LV morphology. So this would be, for example, a tricuspid atresia patient. Dr. Lopez and colleagues published in JACE last year where they compared myocardial mechanics by echo in children who had a single ventricle of LV morphology after Fontan operation to age-matched controls. The Fontan cohort had normal longitudinal strain, but did have reduced basal mean circumferential strain compared to controls. They also had a higher apical rotation, but a lower basal rotation than normal. And these findings might be related to an abnormal myocardial fiber orientation. Dr. Lang spent a moment talking about how important fiber orientation is when measuring strain. In single ventricles, their fiber orientation is not normal. And so that's an important consideration to take into account. Please go to the next slide. So what we have here from that paper is two images on the left side, which were the group of controls. The upper left is the basal section of circumferential strain, and the peak basal circumferential strain there is negative 25.6%. The apical circumferential strain is negative 19.8%. On the right-hand panel, you can see the single left ventricle patient, and the peak basal circumferential strain is negative 15.9%, so quite a bit lower than normal. But the peak apical circumferential strain is negative 18.8%, so very similar to normal. So you can see again that they have a abnormal basal circumferential strain in these patients. Next slide, please. And then finally, just to mention a few other uses in the pediatric population. In our lab, we've done research on cardio-oncology patients, finding that those patients did have abnormal strain even in a cohort of patients who had normal function by traditional measures such as ejection fraction and fractional shortening, and that it was dose dependent when they received anthracyclines. We also have looked at it in the pediatric transplant population. These patients, we hope to get 15 to 20 years out of their graft, and it's very nice to be able to follow strain in these patients. We're just getting into exercise stress echo in pediatrics, and there's some different ways that you can look at coronary manipulation in these patients, in strain in these patients. One is in patients who've had coronary manipulation surgery like a Ross or arterial switch operation. You can look in LV outflow tract obstruction such as aortic stenosis or coarctation, and in pulmonary hypertension. And then finally, we do like to look at strain in all of our patients who have suspected or proven dilated or hypertrophic cardiomyopathy. Next slide, please. That's all I have for pediatrics. Thank you.
All right, thank you so much, Biff. And we're going to go to questions and answers, but I'm just going to first go over this summary slide here. Where do we use strain imaging? I think you've seen from the talks tonight that there's a lot of use for strain imaging in subclinical LV dysfunction, particularly GLS, either cancer chemotherapy, either prior or current, unexplained dyspnea when you're trying to distinguish HFpEF from pulmonary causes, and in valvular heart disease to clue you in that the ventricle is suffering under whatever's happening with the valve there. Anytime you see LV hypertrophy, get a bullseye pattern, and if you see that apical sparing pattern, that is highly predictive for cardiac amyloid. Coronary artery disease, you can use strain to localize the infarct, predict arrhythmias from the myocardial dispersion, and as the technique gets better and better and faster frame rates, there will be an increasing role in stress and dopamine echo. Assessment of RV function, I think any suspicion for RV enlargement or dysfunction is appropriate to do strain, and certainly when you have pulmonary hypertension, that is something important to do RV strain with. And then you've just heard in pediatrics and congenital heart disease, all the things as above, plus the special events in congenital heart disease, such as single ventricles, Kawasaki disease, transposition of the great vessels, and pulmonary hypertension. And please don't forget to code 93356. And let me toss it over to Akil and see if we've gotten a few questions that have come in over the last few talks.
Lots of questions, probably could do a whole nother webinar on just the questions. A couple general questions I'll start out with is one, now that strain is becoming more common in terms of our acquisition of the images and reporting of the data, how proactive are you in reporting recommendations based on the strain that you're reading, with the assumption that the referring provider either knows what to do with it or doesn't know what to do with it?
Well, maybe Nausheen, you are both a consumer and a provider of strain information. What should we do when we see an abnormal strain?
I actually get asked this question quite often from oncology. And the very first thing I always do is I review the strain myself. I review the strain curves myself. I do a quick synopsis of the patient's chart as well to decide if the patient is symptomatic and the patient should come in for an evaluation. That's easy. If the patient is asymptomatic, it's much more challenging, and I hope that we will get some more information with regards to using strain and starting prophylactic treatment soon.
And another more general question, maybe for Dr. Lang and Dr. Thomas, the role of artificial intelligence or automation in strain measurements, and what you see the future is for this. Roberto?
Well, I'm certainly it's an interesting question. I'm not aware still of any sort of studies. I think we are at a step in which the vendors are trying to improve the way in which we get a reliable automated type of strain. To obtain that with AI would be definitely an improvement, but I think it will take some time.
There's been some early work on this. A fellow named Rahul Deo at the Brigham, formerly of UCSF, has a sort of end-to-end AI-guided echo interpretation system that he does a lot of research in. And in a paper about a year ago, they reported, at least preliminarily, that they could get some estimate of global longitudinal strain from this. But I think that this is a situation where it reminds me of a talk I'm giving in Vienna next week at the EuroEcho meeting on the battle between physics and gestalt. You know, we have a lot of physics in echocardiography, and AI is all about gestalt, just looking at it and sort of sizing it up and saying, this is what it is. And I think you need to combine both. And so I could see AI being very helpful for segmenting out the walls, for deciding where that endocardial border is, for how thick the wall is, setting your region of interest. But I think we have kind of deterministic algorithms that can predict what the strain is. And so once you've got your boundaries set, maybe then you turn loose your old speckle tracking algorithm, and it takes over from there. And maybe AI has a role in quality control, but it's not doing the actual calculations itself. Just a little editorialization.
A couple questions regarding the congenital and pediatric population. Number one, are the values for strain, normal values for strain, similar in children as in adults? And do strain values that are normal change over time? And then a more specific question is about tetralogy of Fallot, a pretty common disorder that we're starting to see more adults in, the reporting of RV strain in patients with tetralogy.
Sure. So there's not too much of an so we're looking at the ventricular strain below. It sounds like a really bad. In tetralogy, with the right ventricle, it's possible to follow these patients over time And I think that the right ventricle is certainly something that should be followed in these patients. We use Gestalt and subjective impression of RV function when we just look at a 2D echo, but if you were to perform free wall strain on these patients, you might be able to identify when they start to have a declination in function, which means that it is time to have them undergo pulmonary valve replacement. And then, can you repeat the first question for me, please?
The first question was on normal strain values in children as they become adults. Does the threshold for normal change over time?
Yeah, so I found that the normal values in children are very similar to what they are in adults. I don't know that there's been a combined study to try and publish combined normal values, but in pediatric patients, we tend to also use somewhere in the negative 18% or so as what we would consider our cutoff for normal.
Another question, couple questions came in on strain in tricuspid regurgitation, particularly RV strain, and also aortic regurgitation, and whether or not these are ready for prime time with respect to guidelines and determining what to do in AI.
Roberto, what do you do with TR?
Well, being that this is something that we have been working on, definitely when you have TR, the measures that we routinely use that look at longitudinal motion of the right ventricle do not work. So I think right ventricular free wall strain is a much better way to follow those patients. So we would need to, and this would be, I think, a very interesting study to do, particularly now in the era in which we do all of these interventions on the tricuspid valve. What we measure routinely in our echo labs in the presence of TR is so preload dependent that one day you might have it and the other second study you might not, that I think it's very difficult to follow patients with TAPSE or the S-wave.
And with regards to aortic regurgitation, I would guess of AS, MR, and AR. AR is the one with the weakest evidence base right now, and so definitely need some more research done on this. There's been some disagreement as to whether you should do some preload compensation for the strain in AR, although to my mind that largely just turns it into an index of LV size. So I would just do regular old GLS for lack of any evidence to the contrary. I would assume that it should be about normal for our normal values, that is, minus 18 or higher. And if you see that starting to drop off minus 16, minus 15, I would take that as a red flag that there may be trouble brewing, even though we may not have entirely pinned this one down just yet.
A question on the acquisition for Maddie. Besides getting a good frame rate, is there anything else we can do from a technical standpoint to improve our strain, lowering the frequency of the transducer, changing the frequency of the transducer, changing the gain?
It's usually just to get a better frame rate, you're really just thinking about the physics of the picture. And so we want to, obviously, like we said, narrow the sector size. You don't want to decrease your frequency because that'll usually decrease your frame rate as well. There are some machines that have a knob that you can actually turn. I don't really like that because it usually decreases the image quality. And so really just decreasing the depth and the sector size are the two things that I can think of. And then sometimes looking at the settings on your transthoracic probe and just making sure sometimes if it's set to a technically difficult patient, it may have a lower frame rate just to start with. So kind of playing around with those. It's really just settings. Gain really has nothing to do with it. And was there something else?
Any other tips you have on the acquisition?
Really none of the color maps don't really work. It's really just making that frame rate go up, and we just have to think about our physics when we do that.
Well, it's clear we could go on all night here. Is there maybe one last pithy question to address here?
So one person asked, in your opinion, what's next? We have 2D, 3D strain. What's next in echo? Maybe this is a good way to end.
Roberto, 4D strain?
No, I mean, what's the next thing in echo for me is artificial intelligence. And I think that will be what we're going to be hearing a lot in the next 10 years.
Yeah, I would absolutely agree with that. And you'll notice we didn't talk much about 3D strain per se. I think it is definitely something that is coming, but is limited by the low volume rates of our current 3D implementations. You know, I'm amazed what these companies can do when you think of the parallel processing they have to do to get a volume rate of 25 frames per second. And there are advantages to doing it in 3D where you know the speckles can't move out of the plane. They're kind of always under observation there as they track around. But it is still very challenging to really do strain at that low volume rate there. And when we look at it in our daily practice, sometimes we'll flip the 3D strain on just for fun, and it typically is a few points lower than the 2D strain, right, Maddie?
Yep.
Yep. Good answer. So I think, and I agree fully with Roberto. This is the era of AI, and I've learned a lot about this in preparation for this lecture next week, and just the explosion that has occurred really since 2012 is amazing. And as computers get faster and faster, the sky's the limit, and we just have to make sure we use really clever algorithms and really ensure against bias in our measurements and things like that. And I think AI is not going to replace us. It's going to make us better. And so I think with that, if we can go back to the slides for 1 second, just to remind you of our general themes of the night. Subclinical LV dysfunction, looking for those special patterns in LV hypertrophy, looking for infarct patterns, looking for predictions of arrhythmias, really being liberal in your use of strain on the RV and in pulmonary hypertension, and then a lot of uses in pediatrics. And, you know, thanks to the folks out there that have been doing strain essentially for free for the last 10 years, we've finally gotten the attention of the payers, and they recognize the value of it. So don't forget to code 93356, and we'll get some reimbursement for this, and that will make it easier to bring it more universally to all of our patients. And one final word from our sponsor. I would like to just invite everyone out there who doesn't want to sit in a snowstorm in January to join us at Echo Hawaii, January 20th to the 24th in the beautiful Hapuna Beach Resort on the Kahala coast of the Big Island there. It's too late to submit your science, but you can still come out and watch the posters above the setting sun, interact with our faculty, take advantage of the education. We are the driest part of Hawaii, so there's very rarely any rain there. And the hotel has been fully remodeled. So I hope we will see you out at Echo Hawaii. And on behalf of my panelists here, I would like to thank everyone for their attention. We have a few diehards in the live audience here. I really appreciate you being here. And I would like to especially thank all of the panelists and Akil, who was excellent at wrangling those questions, and Biff Landeck at a distance in Denver. And I'm glad you didn't get snowed in here, Biff. Thank you all, and good night.